Hello, class. We're going to move on to the pancreas, and we're still on the endocrine system, but we're going to focus on the pancreas and care for patients with diabetes mellitus. So, the concept here for this subject is glucose regulation. So, take a moment to review the pancreas, and remember the pancreas is part of our endocrine system that regulates our glucose production by releasing insulin and glucagon to absorb glucose from the blood into the body or to break down glucose from the liver into the blood. So here's a nice little diagram that shows you the homeostasis that is uh, regulated from the pancreas when it releases insulin and glucagon to really regulate that glucose. Now, we're going to start here on the left side, and we're going to say that we ate a cupcake. Is that a cherry on top of that cupcake? Yeah. So you ate a cupcake, and now you have sugar in your body, in your blood. So your body wants to use that sugar, that source of energy, and to do that, it has to put it inside of their cells. So the pancreas detects a rise in your glucose, and it's going to release insulin, and insulin is going to be the key that allows you to open the door so that your glucose can go inside the cells. So insulin comes and it lets the glucose in your cells, and if you already have enough in your cells, then it stores it here. It stores it in the liver as a glycogen, and because of that, your glucose in your serum and your blood lowers. Now, let's say after that you went into a food coma and you haven't eaten the whole day. So after some time passes by, your blood glucose starts going down. Your pancreas detects this and notices that you need more sugar, so it needs to get sugar from somewhere. So the pancreas uses the alpha cells to release glucagon, and glucagon is going to send a message to your liver so that it can break down the glycogen into glucose and release it into the blood so that your blood can be increased. So now you could use that sugar, that source of energy for fuel for your body. Okay, and this is going to increase your blood sugar, and then you're going to go back to homeostasis. So if we have some type of impairment in with this nutrient metabolism regulation system that is controlled by the pancreas, then we have now what is called diabetes mellitus. Diabetes is a group of metabolic diseases characterized by hyperglycemia resulting from defects in the insulin secretion, insulin action, or both. So, a disorder of carbohydrate, protein, and fat metabolism um, resulting from an imbalance between insulin availability and insulin need. There are a couple types of diabetes mellitus. Type 1 diabetes, that's from an autoimmune disease with absolute insulin deficiency. So these patients, their autoimmune system doesn't allow them to produce insulin properly. So their body doesn't have that key to allow the glucose to open that door. So that's why they don't have that glucose going inside their cell. Type 2 diabetes is from an insulin resistance. So the body does make insulin, but there is too too much glucose and too much insulin here. So the body is going to just become desensitized to insulin, and that's why it becomes resistant to it. Maturity onset diabetes of the young. This is a mutation in the gene that results in the loss of insulin function. We're not going to go too much into that one. And lastly, gestational diabetes mellitus. So this is during pregnancy, usually in the third trimester. And you'll learn more about this in OB. So here's a compare and contrast of diabetes type 1 versus type 2. Diabetes type 1 is the autoimmune disease, so the beta cells, the ones that are responsible for producing insulin, those are destroyed. So that means that there's absolute insulin deficiency. There's not really insulin being produced. So that glucose is going to stay in the serum, in the blood, and it's not going to have that key to open the door. So it can't get inside the cell. It can't cross the blood into the cell. So that's type 1. Type 2, however, you do have the insulin. You do have insulin being produced, but it's the cause is can be genetic or non-genetic factors that cause that insulin resistance to develop, and this can be caused by obesity, physical inactivity, something we call metabolic syndrome. It's factors that affect the metabolism, such as obesity, high blood sugar, hypertension, and hyperlipidemia. So usually these factors, what happens is that not only do they create more insulin in the body because there's too much sugar, but because there's too much insulin, the body just becomes so desensitized to insulin that it just the cells are like, okay, enough. Like I'm done with you, insulin. Like I'm not gonna let you like open the door anymore. Like you open it too many times for glucose. Like stop. And it also changes the morphology of the that like key lock and key. So insulin is no longer able to open that door for glucose. And about 30 million people have diabetes mellitus. So clinical manifestations of hyperglycemia, or also known as diabetes mellitus, you're going to have three principal signs. You're going to have polyuria, polydipsia, and polyphagia. So the three P's. Poly meaning many, and then uria meaning your pee, so you're going to want to pee many times. You're going to have excessive or abnormal large production of passage of urine. Why? Because you have a lot of sugar in your blood, and your body's going to attempt to get rid of it. So it's going to want to pee it out. So that's why you're going to pee and pee and pee. Your body has all that sugar in your intravascular space and not into your cells, so your cells are deprived of that energy. So your body is going to think that it needs to consume more energy inside. So that's why the person's going to feel very hungry. And then polydipsia, excessive thirst, because if you think about it, when your body has a lot of sugar, that's going to change it to isotonic to a more hypertonic, to be more condensed, because there's more solutes to solvents. So your body's going to want to balance that out, and by being thirsty and to kind of initiate that thirst reflex, that's going to help balance your body out. Kind of like when you just drink a can of Coke, you're gonna start feeling really thirsty. Now, because the body is going to try to use fat for the energy instead of your glucose, because obviously it can't use glucose if it's not in the cell, so it's going to attempt to use fat instead. So it's going to break down that fat and form it into what we call ketone bodies. Now those are acidic. So one way your body tries to get rid of that acid is by increasing the respiration. So that way, if you're tachypnic, you're going to blow out that CO2, which is acidic. So that's what we call Kussmaul respirations. And we'll talk more about that in our next slide. There are other signs of diabetes in your body. They can be microvascular and macrovascular. So microvascular, it affects the vascular system, but the tiny ones, like in your eyes or in your feet or in your kidneys. So the high sugar here is going to damage the blood vessels and the neurons around them. So it's going to reduce the neuronal oxygen. This increases nerve damage, nerve hypoxia, poor nerve transmission, results in loss of sensory. That's going to happen in your feet or in your hands. And that's how you get diabetic neuropathy, or eye diabetic retinopathy. So this is going to damage your eyes and increase loss of vision, which can lead to glaucoma or cataracts. And this can also affect the kidneys, nephropathy, because it causes your blood to be more viscous, so increases that pressure, that blood pressure, especially in the kidney. In that blood pressure in the kidney, it's bad because it's too much pressure and it causes leakage of proteins and albumin. So and that it's going to narrow the vessels, and this is going to lead to a decrease of oxygenation. And remember, if there's no oxygen, then it's going to kill the cells. It's going to lead to kidney cell hypoxia and then cell death. That's how we have our renal patients. That's when we start going into like dialysis. For the macro cardiovascular changes, this is going to be more so like the overall systemic high blood pressure, when they have heart disease, when they're being put into risk for heart attacks, or especially for stroke. If in their brain they might be a risk for a stroke in that way, and it could also cause immune changes in the immunity system. It can reduce white blood cell activity. So hyperglycemia has a large amount of unfortunate effects on your body. All right, for those who like trauma, ER, or ICU, here's a little preview of what's to come in 411. So hyperglycemia can cause acute complications that are very emergent, such as diabetic ketoacidosis, also known as DKA, or hyperglycemic hyperosmolar non-ketotic syndrome, HHNS, or which we are now starting to just call HHS. So when they go into diabetic ketoacidosis, what happens is that not only is their blood sugar really high, and they have all the same symptoms, but it goes on for so long that the cells are extremely deprived of that. They're extremely deprived of that fluid, especially, remember, because the intravascular space has a high tonicity level, and so it's pulling water out from the cells. So the cells are extremely dehydrated, and not only that, but it's changing the electrolytes. It's imbalancing them so much that the body is in an acidotic state, especially because remember how we talked about that the body uses the fats to break down and use that for energy. Remember how we talked about how once the body does that, the ketones are formed as a byproduct of that fat, and that's an acid. So when the body's acid is too high, the body tries to breathe really fast, called Kussmaul respirations, and if that doesn't work, then that's when that acidosis from the ketones lead patients to DKA. That's why we call it diabetic ketoacidosis. So the liver metabolizes the fatty acids to produce two water solute types, the ketones. The third type is the ketone acetone. So, but you don't have to know that. Now the other type, HHS, that's when their blood sugar is a way more higher, but they don't have the ketosis, but they're going to have similar symptoms, but they're also going to be dehydrated, and there's going to be an electrolyte imbalance. So and that's why if a patient has a lot of ketones, you're going to smell that fruity breath in their mouth. Diagnosing diabetes requires two tests. This is the main definite test. This is the HbA1c. I'm sure you've heard of this one before. Your glycosylated hemoglobin test, your A1C, as we call it. This is going to measure the amount of glucose in your blood that's attached to the hemoglobin part, hence the name analyzed glucose. So once it attaches there, it's glycosylated. This is a really good measurement for your blood sugar levels, because since your red blood cells have a three-month lifespan, this test is going to measure the average of the first, second, and third past months. So the last 3 months. So that way, if your patient lies to you and tells you that they've been eating good for the past 3 months, this is going to really let you know if they're telling the truth or not. The normal range is 4 to 5.6%. We usually want diabetic patients to be under 7%. So we'll go through the other tests in the next slide. Okay, let's break this slide down because I know it's a lot. We talked about HA1C. If it's greater than 6.5%, then the patient is a candidate for diabetic mellitus. So that's one test. The second test is going to be either the random glucose or the fasting. Okay, and the fasting, if the patient is pregnant, then they're going to do the oral glucose tolerance test. So we're going to start with our random blood glucose test. If the patient has symptoms, they're going to have the 3 P's, right? The polydipsia, polyphagia, and polyuria. So if they're positive for HA1C, they have symptoms, we're going to go ahead and just do a random blood glucose, because if they have symptoms, then you want to check their sugar right then and there, because it's more likely that maybe it's greater than 200. You don't know if it's 300 or 400. So if it's more than 200 milligrams per deciliter, then sure enough, they're diabetic, and with also the HA1C. So you need HA1C, and then you have this one to diagnose them. If the patient is not symptomatic, then their sugar is probably not high, but you want to screen them when they're fasting. Because when they're fasting, they're not going to have a lot of sugar, right? But you want to know if their body is their pancreas, if there's not an imbalance there. So you're going to have them fast. You're not going to let them eat for 8 hours. So let's say they come to the hospital in the morning, they haven't eaten anything at night, no breakfast. So their sugar should be around 70 to 100. So here, fasting, it should be less than 100, right? Because you don't have any sugar. If you take that blood and it shows you that it's more than 126 when the person has fasted, then there's a problem, right? Because your sugar shouldn't be that high. So that means that you probably have diabetes, especially if you have this test that's over 126. Plus you're over 6.5% HA1C. Okay. If the patient is pregnant, then you're going to have them fast as well, and you're not going to let them eat any food or drinks, and then you're going to give them glucose load, so 75 grams of glucose, which is probably like a big bottle of Coke, because Coke has like 40 grams. So 2 of those should be like almost 80 grams. Give them that to drink, have them chug it down, and then wait about 2 hours, because the GI tract needs to let the sugar kind of absorb into the blood. So after those 2 hours pass by, then you can go ahead and check their sugar. Their sugar should be a little bit high, but it shouldn't be higher than 200 milligrams per deciliter. If it's more than that, then that means this is positive for diabetes, and then you have the HA1C, which is positive, so then you can diagnose them. For the oral glucose tolerance test, the normal range should be less than 140 milligrams per deciliter. Okay, if it's more than that, but not exactly too high, like if it's between 140 and 200, then they're in the pre-diabetic state. Okay, here's another representation of what I said in the last slide, that your fasting blood glucose here, if it's normal, it's going to be less than 100, but if it falls in the 101 range to less than 126, then the person is pre-diabetic, but if they're more than 126, then they're diabetic. Whereas the 2-hour oral glucose test, if it's less than 140, then that is what we're aiming for. But if it's between 141 to less than 200, then that means that they're pre-diabetic. And if more than 200 milligrams per deciliter, then they're diabetic. Okay, so we looked at hyperglycemia, so high levels of blood sugar and what that looked like. But now let's look at the opposite. Let's look at hypoglycemia. What happens when the person doesn't have enough blood sugar? Maybe they haven't eaten anything, and maybe they got too much insulin and now their sugar is coming down. So if their sugar is low, like around 60 to 70 milligrams per deciliter, or lower than that, then a person might exhibit some symptoms of hypoglycemia. And I'm sure that you are all familiar with your symptoms. You know, when someone gets hangry, that's usually because they haven't had any food, which usually means their sugar is low. So that's their symptom. They get angry, they get hungry, irritable. So a way to remember this is a high washed. H is for hunger, okay, because obviously you're hungry because you don't have sugar. I is for your irritability, hangry. H and I equal hangry. W means you're weak. Person gets weak because there's no energy. A, anxiety. S, shakiness. The next S is sweat. The next H is a headache. And then the last T is for tachycardia, so fast heartbeat. They can also get dizzy or impaired vision. So just remember high washed. A patient that is too hypoglycemic, it might need intervention, whether their sugar is 65 milligrams per deciliter or lower. They're going to need some sugar. So your interventions are going to depend on their neural status, because if a person is weak but they're still awake, lethargic, if they're still able to listen and swallow, then you can give them something PO. You can give them something by mouth. And if they're too lethargic, if the sugar is way too low and they're obtunded and they're drowsy, then you're not going to be able to get anything in their mouth to feed them. So if that's the case, then you might have to resort to IV medications. So you want to first assess their neural status. Can they tolerate PO? If they are awake and alert, then give them 15 grams of some simple carbs. This just can be a small juice box, a small apple juice, sugar. And then after 15 minutes, check their sugar again. And their sugar should be higher. If they are not awake, or if they can't tolerate anything PO, then you want to give them 1 amp of D50, dextrose 50% IV. And since that IV medication surpassed the GI system and it's already in the blood, then you don't really have to wait 15 minutes to recheck that, right? Because their sugar is already high because it's in the blood. So you can recheck that sugar immediately and it should be higher. And if that sugar does not increase, then you're going to go ahead and intervene again and give more sugar for the patient. Or you can follow your policy, and usually the sugar, if it's higher than 70 milligrams per deciliter, then that means that we've reached normal glycemic levels. Diabetes is going to require a lot of education, and this is going to require a lot of willingness from the patient to change. So you want to let them know to regulate their blood glucose levels by monitoring their sugar levels before meals, ACHS. AC is before meals, HS is after bedtime. Because especially if they're taking insulin or if they're taking some blood sugar pills, then this might bring the blood sugar down, but we don't know if they might have too low of a sugar. If they're having symptoms of hypoglycemia, teach them that as well. Teach them to carb count, to change their diet. Mediterranean diet is a really healthy diet to be on. look at the labels, tell them to count how many carbs they're having, or they could to substitute things. For example, if they're going to want to have a can of Coke that's like 40 grams, teach them that they can instead only drink half of that can of Coke and have 20 grams left over for something else. So that way they can maybe eat, I don't know, maybe like a piece of bread that's 20 grams worth of carbs. Some patients are not going to be willing to cut things out of their diet, so you have to really be patient centered on this. You have to meet them halfway if they're not going to want to give up their sugar. I know my grandma does not give up her Coca-Cola bottles, and it doesn't matter what I do, she won't give that up. So instead, I buy her like the little small mini cans that are only like 20 grams. So that way she can at least have that and then have something else. So that she's not getting like 40 or 60 grams of Coke. You want to limit the alcohol intake because alcohol has calories, believe it or not. Shots have a lot of calories. You can also impair your liver from producing glucose, and that can lead to hypoglycemia. So it can alter your blood sugar levels in many ways. Teach your patients to exercise. Exercise helps increase insulin effectiveness and sensitivity to the body, and it helps regulate blood sugar as well. And again, you want to have patient-based care. Remember the Houston, because exercise is going to be something that your patients are not going to want to do, or maybe they're not able to do. Maybe they're too heavy to run. So in that case, you want to teach them to have a brisk walk, or you can teach them to do little things and work their way up. You want to tell them to reduce stress, maybe if they want to journal or meditate. Again, the patient's going to have to be open to this. Teach them to have foot care because one of the microvascular changes is peripheral neuropathy. The foot care and wound healing becomes diminished. So you want to teach them to really have good foot care, make sure they have good footwear, assess their feet for any cuts and scrapes, and to monitor for neuropathy. So yeah, you have to really encourage compliance, and then we'll go over the sick days rules in the next slide. So what happens when you're sick? When you're sick, your body is under attack, right? So the immune system is fighting. You're doing a lot more work. It's a lot more stress that your body is on. So that's going to release a lot of cortisol, and cortisol is going to help with your immune system, release WBCs. But remember, cortisol is also going to release more sugar into the blood. So like you are going to have a lot of high sugar when you're sick, right? So why is this bad for diabetics? Because the obvious is their sugar is already high in the first place. So when they're sick, these are some rules to go by. You want to have them check their blood sugar every 4 hours, much more frequently than they're already checking it. You want to test their urine to see if there's any ketones if the blood sugar is higher than 240 milligrams per deciliter. You want to tell them to definitely not skip their insulin or oral antibiotic meds, or anti-diabetic meds, unless their doctor says so. And you want to teach them to drink more water because, again, the body's going to need more energy, more fluids when it's sick, when it's under the stress. And also teach them to continue their meals regularly and to try to not have too much high calorie intake, especially high calorie drinks. And let them know to get rest as well. Managing diabetes can be done through insulin replacement and or oral hypoglycemic agents. And we're going to go over these two in a bit. And they're going to have diet and exercise in their regimen as well. So let's go over your oral medications to treat type 2 diabetes. The first category here is your thiazoles. And this one, along with biguanides, they have the same function. These medications work by increasing the sensitivity to your body, your peripherals, to increase insulin sensitivity so that sugar can go inside of the cell. And they also work by controlling the hepatic production of glucose, so it's less likely for it to be broken down and going into the blood, so it decreases that. So that's how it brings down your glucose levels. Examples of your thiazoles, I mean, are your Actos and Avandia. And for your biguanides, the main example here is metformin, also known as glucophage. And we'll go over glucophage in the next slide. The next category is your sulfonylureas. Examples of these are your glipizide, glimepiride. This one, along with meglitinides, they stimulate the pancreas to make more insulin. So you're going to have more insulin available to help the sugar go inside of the cell. So yeah, it lowers fasting glucose by triggering the release of the insulin from the beta cells. Examples of meglitinides are your nataglinide and your repaglinide. Lastly, your alpha glucosidase inhibitors. They slow the absorption of starches. So they're starch blockers. They decrease the absorption of starches when they're in your intestines. So it prevents sudden glucose surge after you have meals. So it kind of slows that process of breaking down the sugars after you eat. The example here is your Precose. So let's talk a little bit more about biguanides. Your prototype here is metformin glucophage. So they work by, again, they do not act directly on the beta cells of the pancreas. Instead, they act on the liver. They reduce the release of glucose from that stored glycogen. They also help to increase the sensitivity of insulin receptors to the binding of natural secreted insulin. And the last way they work is by reducing the absorption of glucose from the intestinal tract into the blood. So that means that these drugs will lower the blood glucose to normal without causing so much hypoglycemia, because they're not really working on the beta cells, so they're not really increasing the release of insulin. So because of that, this drug has a lower chance of causing hypoglycemia unless it's being used with something else like insulin or another medication. It also comes in immediate release as well as extended release. So teach your patients that if there's an XL or an XR, that they're going to be released over time. So do not crush those medications. The FDA has placed a black box warning on this medication because we have seen that when this medication is given, it can cause lactic acidosis. So if you give this drug within 48 hours to anyone who has gotten it, a test with a contrast dye, like if they're getting a CT, if they have just received this medication within 48 hours and they're going to get a CT scan with a contrast dye, this can cause lactic acidosis, and the chance for that is very high. So you will see that often when the patients are in the hospital, they are on metformin, but the prescriber will usually cancel that order and place them on insulin to reduce that chance of them getting that lactic acidosis in case they need to get a CAT scan. So because it doesn't get along with the contrast dye at all, or like any angiogram procedures, because that can also cause a kidney failure if that's the case. So you want to assess that whether the patient's going to go, if they're going to get a contrast dye exam, like a CT. You want to pay attention to that. Check their kidney functions. You want to make sure that the patient is clear to take this medication. We want to make sure that the creatinine level is normal, 0.5 to 1.1-ish. And we definitely don't want to give this metformin medication to someone whose creatinine level is more than 1.4, because otherwise they're not going to be able to secrete this medication from the kidney, and it's not going to go into the body, and it's going to stay in the body. In addition to those side effects, they can also have GI distress effects such as nausea, vomiting, diarrhea. It can cause a lot of bloating, flatulence, indigestion, abdominal pain. So things to consider when you're giving this to patients is that to prevent GI distress, you want to tell the patients to take this medication with food, and then teach them that because there's a risk of lactic acidosis when they're taking metformin, they should really be drinking a lot of water to prevent any dehydration, and then that's also going to help the kidneys work better as well. So moving on to insulin therapy. Insulin is derived from beef and pork, so that's one of the big things with this. Patients can have an adverse reaction to this medication, an allergic reaction if they're allergic to pork or beef sources, or if your patient is taking an insulin that contains substances such as zinc. So insulin regimens that are being prescribed are trying to pattern or resemble the way that insulin normally is released from a healthy pancreas. So insulin, as we know, it's injected subcutaneously, and there's different insulin types. Insulin is a high alert drug, meaning that when given, it can cause harm if the wrong dose is given. If the patient who was not prescribed insulin has gotten insulin, or if the dose is not given to the patient that needs it, there could be some side effects. So insulin is one of the top 3 medications that actually bring your elderly patients into the hospital due to complications. And because of this, it requires 2 licensed RNs to check off the dosage. So before you give insulin, you need to have another nurse look at it and check it off to make sure it's the right medication. Insulins they're going to vary according to how fast they work and how long the effects are. So that's going to be the action, the onset, peak, and the duration. So that's pharmacodynamics, the kinetic movement of the medication through the body. So we're looking at rapid acting, short acting, intermediate, and long acting. So another thing about insulin is that it can cause hypoglycemia. That's a very potential adverse effect with insulin therapy. However, we do know that the longer acting one, which is Glargine and Lantus, it has a slightly reduced side effect of hypoglycemia. However, because you're giving synthetic insulin and it's lowering the blood glucose levels, there's always a potential of hypoglycemia. So you have to monitor for that and intervene if need be. The normal pancreas will stimulate more insulin to be released when the food has been eaten. And those are what we call the bolus releases of insulin. So when a person eats, then the body is going to detect that, and then it's going to release a bolus, like a big chunk of insulin. So that the normal pancreas has both a basal and a bolus control. So that's a bolus control. The basal control is insulin that's released a short amount throughout the day. So we want to mimic the body's natural regimen. Some nursing considerations to take whenever insulin is going to be given is that before a meal, it is critical that the patient eats that meal and have sufficient amount of calories within about 30 minutes of that insulin, because if you give that insulin before a meal and the patient doesn't eat, then you just given them some medication to have their sugar go down in the body, increasing the chances for hypoglycemia. So you want to test the patient's blood sugar levels before giving any insulin to make sure that the patient is willing to eat. If that patient is MPO or they've been nauseated or been vomiting, it would not be a good idea. You're not using your good clinical judgment to give the insulin to somebody who's not going to have any sufficient calorie intake. And insulin types they're not interchangeable, so you want to make sure you double and triple check your physician's orders, that you're calculating things correctly. Always use an insulin syringe that has been calibrated to that given insulin. So never use any other syringe that's not an insulin syringe. So check that the insulin syringe that you're using, check that like it hasn't been opened, or and also check that when you open a new insulin vial, that it needs to be dated and make sure it doesn't expire, because insulin, an open vial usually expires within 28 days of it being open. Do not use any insulin that is cloudy unless it's supposed to be cloudy. I think the intermediate acting insulin, I think that's the only one that's cloudy. But the rapid and the short acting ones, they shouldn't be cloudy. Check that the order, check it carefully for the exact type and that the amount of insulin that you're going to be giving, that it matches. And then last thing, when you're giving insulin, you don't need to aspirate. You do not need to massage the site. However, make sure you rotate the sites, because if you give insulin in the same site, then you can cause what is called lipodystrophy. So it changes in the amount of fat in a patient, and that's going to cause the fat tissue to be very asymmetrical, and it's going to look a lot different. The density of the tissue at that site, it will cause like a reduced absorption of future insulin use as well. So remember how our insulin therapy is going to mimic uh, our body's glucose releasing mechanism. So we want to separate that into a bolus or a basal insulin type. So remember, the basal is the body's natural releasing of insulin, and this happens when your pancreas just releases a constant amount of insulin, and it usually keeps your blood glucose levels normal between meals, and it also balances the liver glucose production. So that's what we call it, basal level. And insulins here that mimic that is the long-acting insulin, your glargine, detamir, and also your intermediate-acting insulin, so NPH, and your some of the premixed insulins as well. The other type is a bolus. Remember, a bolus is remember how we have an IV bolus, so we have a lot more in a short period of time, so we have a lot more insulin in a short period of time. This happens when you like carb load, when you eat a lot of sugar. So the pancreas will stimulate more insulin to be released when the food has been eaten. So that's what we call a bolus. And a bolus here, examples of the insulin types is a fast acting, such as your rapid, your regular insulin. And it could also include some of the intermediate here. Oh, sorry, I mean just the rapid and the regular for your fast acting, whereas your basal is your intermediate acting and your long acting. Our first type of insulins are the rapid acting insulin analogs. These are the logs, so you want to give these while the plate is hot. So give these right away, because the onset is within 10 to 15 minutes. This insulin is going to start acting, and it's going to start lowering the blood sugar. It's going to peak in about 30 to 60 minutes, and it's going to last about 5 hours. So give this right before the tray comes, or the tray should already be at the bedside ready for the patient to eat. And if they're not going to eat, then you really should hold this medication. Your short acting, also known as your regular insulin, is going to have a big R on the label. This means it's regular. This is your other bolus type of insulin medication. It's not going to be as fast as your logs, your rapid acting, but it is still going to be fast. The onset is 30 to 60 minutes with a peak of 2 to 4 hours. Duration is going to be a little bit longer than 5 to 7. So this one, you should, because it starts in 30 minutes, then you have 30 minutes before the patient should eat. And this one is the only medication, the only insulin that can be given through IV. The rest need to be given sub-Q. So this one can be given with an IV, as an IV push. It's usually used for DKA or HHS patients when they need an IV drip. Moving on to your basal insulins, your intermediate acting, the N insulin, we call it NPH. This one's going to last longer, so onset is 1 to 2 hours, peak is at 6 to 12, and duration is up to 24 hours. This one should be given, as a rule of thumb, 30 minutes before meals, even though it doesn't have an onset of 1 hour. And this one is the only insulin that is usually mixed with regular insulin. And you can tell by the cloudiness how some insulins are clear and some are cloudy. Well, this one's cloudy, and it's attributed to the protamine and the zinc suspensions in it. So our long-acting insulins. These include Lantus, which is glargine, and Levemir, also known as Detamir. The onset for these medications is about 1 to 2 hours, and the duration is 36 hours. This long-acting insulin does not have a peak, it's peakless, so there's no risk for hypoglycemia. You don't have to worry about giving this medication at nighttime when the patients are not eating, or if they're not going to eat for a while. This one is usually given once a day in the evening, and it does not mix with any other insulins. That's usually why this medication comes in that pen, so that there's no risk of it being accidentally mixed with another type of insulin. However, my hospital actually just switched this pen, so this long-acting insulin comes in a vial now that we have to draw up. So it can look that way too. Here's an example of combination insulins. Usually the MPH and the regular will be combined. And examples of these are shown here. Usually you have a Humulin, which is 70% of the MPH and 30% of the regular. For this one, it's good for people who have a hard time seeing, who are shaky. Usually the older adult population who don't understand the concept of mixing, they come pre-mixed already. And the onset here can be, remember, you have to consider both, because now you have two types of insulins, right? When you're considering your pharmacodynamics. So your onset is 30 to 1 hour because it has regular insulin, and it also has MPH, so you'll have a dual effect of these onsets. You're going to have two peak times now. The patient's going to be at high risk for hypoglycemia because you're taking both of these. So just remember to consider the onset, peak, and duration for both of these different types of insulins. Here's a graph that summarizes your pharmacodynamics. All your insulins, your rapid, short-acting, intermediate, and long-acting are all here. It allows you to compare the onset, the peak, and duration. So the longer that these take into effect, the more time you see it start going down here at the bottom. And then here you can see the time frame. So at the time that the insulin is given, how long it takes before this insulin has an onset, and then how long it takes before it peaks. So right here you can see the orange, it's going to peak faster because that's your rapid, right? Your regular should peak next in your MPH. And then remember how we said about your long-acting that it's peakless. It's not going to peak, so you're not going to have symptoms of hypoglycemia. And then the duration should be longer for your long-acting, right? So here you can see your Lantus, your Levemir lasting longer than, say, your short-acting and intermediate and your rapid there. Some last considerations that you should take as a nurse is to always check the blood sugar before meals and at bedtime, especially if you're going to administer insulin. Always rotate the injection sites to prevent that lipodystrophy. That's that rare syndrome that causes a person to have fat, to lose it in some places and gain the fat in other places. Know the pharmacodynamics of your insulin medications. Know the signs and symptoms of hypoglycemia, especially when you're giving the insulin, and especially at those peak times. You want to assess for hypoglycemia during exercise, if too much insulin is given, if they skipped a meal, if the patient is NPO, vomiting, skipping meals, or if their sugar is less than 100, then you want to consider not giving any insulin. Sometimes at the hospital, when the sugar is less than 140, it says to not give any insulin. And some last considerations: always refrigerate your insulin, especially because it lowers the potency of it. And make sure you label that bottle, because after 30 days, it's time to throw it away. It becomes expired. Keep it out of direct sunlight and high temperatures, because that will decrease the efficacy of that insulin. Always have a second nurse check your insulin. You do not want to be held accountable for giving that insulin without another nurse verifying it. And always initiate safety checks with all your syringes.